Good afternoon, respected dignitaries on the stage, and Vaishali for giving this amazing talk, and Sudipta for inviting me. It's so nice to see my LDP people, Srini sir also in the crowd. So here I go. Thank you so much, Vaishali, for your detailed theory. But yes, we all know that theory is something what we learn just to get marks, and practicality is what we need to please the patient. I'm sure that we cannot impress a patient with theory. I think you all can see that there's only one person who's standing outside the crowd. I mean, we are all together supposed to be. So she always wants to be someone who's someone different, who does something really good and something always different from the rest of us. So I'm sure that with the theory, it is given that same thing about what an IOL is. I'm not going to go in detail. We all know that the types of IOL, what I was supposed to do is how to achieve the monovision in phaco. And to do that, apart from what she said about the dominant and the non-dominant eye, all of us should have a perfect keratometry axial length and the perfect formula to decide the IOL which we are going to put. Because we know that even before we decide that we are going to give a different vision for the other eye, there should be an emmetropia on the eye we operate. She goes to whatever level to show that I am the boss. So yes, we know that I'll be stepped upon also, but I'll try my best to make sure that I try to prove her wrong. So what are the difference between SICS monovision and phaco monovision? One, she actually showed a large incision. We all know that the SIA, we almost keep it like if it is less than 2.8 and if it is near the limbus is what we call it as the SIA is neutral. And I'm not sure that whether she can calculate an SIA to decide on the astigmatism, but in phaco, I'm sure that we know our SIAs as well, as long as we are doing it less than 2.8. And there are no toric lenses in SICS, whereas I'm sure that the debate on the toric lenses will also be decided. But as such, phaco you do, there is definitely something you can do on the toric lenses. With the advancement in technology, we know that FLAX, the laser-assisted treatment, you can also take care of some amount of astigmatism, which is there and need not be toric-induced. So to achieve monofocality, it is not only the spherical monofocality of 0.75 diopters, which we all know we have to keep it in the non-dominant, but to take care of the astigmatism as well. And yes, no longer I think patients prefer their eye to be injected, because I'm sure that is what we all talk about is topical anesthesia and you get operated only with drops. So the tissue handling is also much less in phaco. So we all know that the importance of axial length measurement can be with different that's also very important. And as she showed a small video of SICS, this is just a small run through of a phaco, which is actually going to be the best method where we can decide on what type of monovision we can plan. So in terms of request, she mentioned that yes, you needed 5 to 5.5, but why? So that the lens stays in the center and you have an effective lens position. So I always prefer the stop and chop technique. You can see that the tissue handling is less and patient is operated only under topical drops. There is less amount of endothelial damage, and in terms of the comfort that the patient can get back to their routine life from the next day or the day after is something which I'm sure that they are going to enjoy. And you have these post-refractive, which you cannot do in SICS and plan a monovision. So post-refractive you should definitely take care of in the ASCRS calculator. And what is my take-home message? I think there is no other take-home message. There's only one message, that do phaco and then try to do a monovision and not SICS. Thank you. She's a wonderful person. Thanks, Vishal.
That was a very good presentation by Nisanth.